Hi everyone, I'm Soosan Jacob and I'm going to show you a case with false channels formed during Intacs implantation. Now, before I actually show you the case, let us understand what false channels are and the turnaround technique to tackle it. A false channel can be identified by the radiating folds that are seen from the leading edge of the intact segment. When this happens, one should stop pushing further forwards as this is definitely going to lead to the formation of a new plane which is separated from the old IntraLase channel by an internal lip. The more you push, the more this false channel is going to be enlarged, and the internal lip can also be seen clinically as seen here. When a false channel happens, the technique that I described was what I called as the turnaround technique, and here instead of pushing further forward, the segment is removed and inserted from the opposite side. The second segment is then used to further push it forwards until it crosses the internal lip from the opposite side. This flattens out the lip, and the intact segment is therefore able to regain the IntraLase dissected channel again. The final placement is done by engaging the Intacs with a reverse Sinskey hook and pulling it into position. This was a case that was being performed by a fellow, and I was called up to the operation theatre to help out because there were false channel creations on both sides. Now, when there is a false channel on both sides, obviously the turnaround technique cannot work easily. You can see that's the length of the false channel dissected on either side. I do go ahead and try to insert the segment and see if I would be able to regain the original IntraLase channel, but as I explained earlier, because of the lip that separates the two channels, it is almost impossible to be able to regain the channel from the same side. However, when I try to do it from the opposite side, the same happens and I end up cleaving the false channel. The radiating folds can be seen at the advancing edge. The increased resistance again denotes the presence of a false channel. My plan, therefore, is to create new femtosecond channels the next day at a slightly more superficial plane and a slightly different axis. I very carefully mark the old false channels with a marker pen so that I'm very sure about where my new channels are going to be created. And then I apply the suction ring and decenter it slightly superiorly purposely. Now I applanate the cornea, and once the cornea is applanated, I again decenter the ring using the cursor so that the new ring that's going to be formed today does not overlay the old channel formed the previous day. But as the channel starts being dissected, you can see this undissected area at one point, and you can also see a gas breakthrough happening into the old dissected channel as the entrance incision is being formed. Now this indicates that the old channel has also been penetrated into, and some of the cuts are not full. The incision cut is not fully cut, and you can see that I'm having difficulty opening it up. But this is relatively simple to tackle. The Intacs, you can see, is not entering through the partially cut entry incision. As I said, this is relatively easy to tackle, and all I do is go ahead and cut the incision open using a Vannas scissors. Once this is done, I insert the first segment, and I try to keep it as much away as possible from the old channel, but you can see that the first thing the segment does is to try and enter the previous false channel. I withdraw it and again purposely try to stay clear of it and try to push the segment through the new channel, and I'm more successful this time. It goes through with relative ease, even though some amount of pushing is required. And as with Intacs implantation, you always use short horizontal pushes instead of long ones to avoid the creation of false channels. Once it has gone in reasonably, I use a blunt rod to try and push it in further. And now I go on to the second segment, and you can see that as I'm going through, you remember that there was a portion of the channel that was not dissected, and that portion is now interfering with placement of the intact segment from the opposite side. So what I do now is utilize the turnaround technique for getting the first segment to come and lie inferiorly, and now the second segment would be therefore the superior one once the turnaround technique is over. As you can see, the second segment is a perfect instrument to be able to do this because the ends lie against each other with perfect apposition. But as I keep pushing, you can see that the tip breaks, and it is generally at the tip that the intact segment breaks because that is its weakest point. However, I'm not too much bothered by this broken tip. I try to pull the second segment into position, and for this I try to regain the IntraLase dissected channel using a reverse Sinskey, but you can see my reverse Sinskey is not progressing further, and therefore what I do is continue to try and push the second segment forwards, and thereby push also this first segment forwards, and I get it to move away as far from the entry incision as possible, and I also close the entry incision with sutures. You can see that the patient's uncorrected and discorrected visual acuity improved to 6/9 or 20/30, and this is the 1 month postoperative appearance of the patient. Thank you so much for watching.